can in our time today, and we'll alternate between online and live operator calls as necessary. And without further ado, today's presenter, Ms. Linda Perico.
Thanks very much, Candace. Good afternoon, everybody, and thank you for joining our webinar this afternoon. I'm joined here in this conference room with Candace and with my colleague Annette Galassi, and Annette will be helping to facilitate our question and answer time at the end. And if I stumble on the basic science questions, Annette's going to be here as my backup because that's so not my forte. But we're delighted that so many people registered for this webinar, and we know that people will continue to join as we get started. And I just want to let you in the audience know that you're joined by a wide variety of health professionals, cancer control specialists, public health specialists, educators, trainers. There's a number of clinical people joining us on the call today, including clinical research nurses. And we know with this broad spectrum of people, we probably have a broad spectrum of experience joining on the phone, everybody from novices to experts. And that's fabulous. And our goal for today is that everybody walks away with either a refreshed understanding of information that they haven't focused on for a while, or for those of you that are new to the area of cancer, starting to walk away with some foundational concepts and some foundational knowledge, and certainly for all of you to walk away knowing about really valuable resources that are available to continue your learning, resources that are available through the National Cancer Institute. So, we will get started. As soon as oh, hi, that's me. Hello, everybody. Moving on. So our objectives for today are we're going to start in the beginning. We're going to talk a little bit about how cancer develops. We'll discuss the purpose of screening and early detection. We'll talk about a number of barriers to screening, why people don't participate in scheduled screenings. And we'll spend some time talking about how cancer is diagnosed and staged. And then, as Candace said at the end, we will have time for questions and answers. So what is cancer? Starting at the beginning, what is cancer? The word cancer, just to remember, it's a term for diseases in which abnormal cells divide without control and invade nearby tissues and can also invade tissues distant from the origin, the location of origin. So if we start in the beginning, looking at normal cells and how normal cells grow. So this may be basic and familiar to most of you and new to some of you, but my explanation is going to be pretty simplistic, so no one will get lost. The body is able to, as you know, the body is composed of many different kinds of cells, many types of cells, and in normal tissues, the rate of new cell growth and old cell death remain a constant. And it's a homeostatic mechanism whereby the number of new cells is the right amount when cells finish their useful function, and when they're ready to die, they go through a natural process of cell suicide, also known as apoptosis. And we're able, through this very structured, very organized, an amazing process to always have the right number of cells that we need in the right places for our body to do its work. So you know you've always got enough skin cells. You've always got just the right number of skin cells. You've got just enough hair cells, or maybe not. Or in my case, just too many fat, no, we won't go there. But so just to know that there's a normal process that's very regulated that allows the body to maintain a homeostatic pattern. What happens in cancer, in the bottom half of the slide, we see the process of carcinogenesis. And we see that that cell, because of changes to the DNA, will cause mutations that each time the cell divides, those mutations continue. And eventually, through this process, with the intervening genetic changes and mutations continuing, the normal mechanisms that control growth are overcome, thus allowing for overpopulation and uncontrolled growth of cells. And so that ends up with what you see on the right-hand side of the slide, which is a tumor growth, also known as a neoplasm. And so in this slide, we see how that loss of growth controls allows the cells to continue dividing in a way that wouldn't be normal and in a way that doesn't support the structure and the function of that particular tissue. And as we move down through this slide, you can see on the bottom one of the first hallmarks of a neoplasm, which is you see those cells invading through the basement membrane of a cell and moving into underlying tissue. So this demonstrates the ability of cancer to invade locally within the area in which it started. And moving into this next slide, this highlights a couple things for us. The first is the difference between a benign tumor and a malignant tumor. So a benign tumor, like a benign fibroid tumor, for example, will grow locally, but they tend to be enclosed in a fibrous sheath, and they're stopped from having that uncontrolled growth. And so the hallmark, the difference between a benign tumor is while it may grow locally, it doesn't have that characteristic and doesn't have the ability to invade locally or to metastasize widely. So a benign tumor can generally be removed. Once removed, it's not going to come back. On the right-hand side of the slide, we see that continuous progression over time of continuing genetic changes and mutations that allow for that uncontrolled growth. We see the enlarging tumor mass, and we see on the far right-hand side of the slide the hallmark of cancer that makes it really a dangerous disease, and that's the ability of the cancer cells to move into the blood system or into the lymphatic system and thereby traveling to distant parts of the body. So you're probably familiar with the term metastasis, which refers to this very process. And so you see at the bottom the occurrence of time. So this process happens over a long period of time. Depending upon the cell of origin, the nature of the changes going on, that division of cells and the growth of the tumor mass may occur more rapidly or less rapidly in some cases, but in all cases, it's over a period of time, and usually, in many cases, a period of many, many years worth of time. And that fact is important to remember because that creates the opportunity for prevention and for early detection and for screenings that we'll be talking about. Okay. So moving on. Genes and cancer. So this goes back to very basic biology, and what we said was that cancer results from the loss of normal growth control. So here's a really quick and simple look at how that happens. So we see on the right, in the nucleus of the cell, there's packets of DNA molecules called chromosomes, and inside the chromosomes are genes. Genes are inherited instructions, and these genes instruct the cell on how to build a specific product, and in most cases that product is a particular kind of protein. So we said that changes occur in the genes that contribute to cancer. So what kinds of things is it that might change or mutate these genes? So on the left we see a variety of scenarios. The first is chemicals may cause genetic changes. So with chemicals we can easily think of numerous carcinogens. The one that comes, first to the top of mind is cigarette smoke. Secondly, viruses may play a role in genetic changes. Viruses injecting their genetic material into that of the cell. And when we think of viruses, we think about the human papillomavirus, the HPV virus. And finally, radiation may cause mutations through damaging the genes. And heredity plays a role because people may pass on alterations in their genes that make their offspring more susceptible to a particular type of cancer. So this has been like just a really, really superficial look at some of those basic things that contribute to the development of cancer and helping you to understand the difference between benign and malignancy and a little bit of that process. But here's a couple resources on NCI's website, cancer.gov, that I would really encourage you to take a look at. Whether you fall into the novice range or into the expert range, both of these, I think, will appeal to both groups of learners. The first is a series on cancer.gov called the Understanding Cancer series, and it's a series of PowerPoint slides with notes attached to them. And in the Understanding Cancer series, there's about 20 different topics ranging from the basics of cancer all the way to genomics and proteomics and angiogenesis and personalized medicine. So it's an incredibly wonderful resource. I would encourage you to take a look at that. And the second is the NCI Cancer Bulletin. And if you're not already a regular reader of the bulletin, I would really encourage you to sign up for it, allow it to be delivered into your email inbox, and to take a look at the research highlights, because the bulletin does, I think, one of the best jobs of any resource that I've seen at taking the latest scientific and technical advances and really being able to translate it into understandable language that allows you to take that information and put it into context and really start to develop some understanding of it. In the latest Cancer Bulletin was a great article. I just read it this morning, but I probably can't repeat it to you. But it was about new genes that were discovered in melanoma, and it's some really serious, important new findings. So anyway, please take a look at those two resources. Moving on. So when we think about cancer, where does cancer develop? It can develop basically any place in the body. But there's essentially 4 different types of cancer, different large classification categories. The first being carcinoma. Carcinomas are the most common type of cancer, and they arise from cells that cover either external or internal body surfaces, the lining of organs. So lung, breast, and colon you see here, and you know that these are the most frequently diagnosed cancers in the United States. Carcinomas also occur in the bladder as well as in the prostate. We look over on the other side, we see the leukemias, which you know are cancers of immature blood cells that grow in the bone marrow and then spill over and accumulate in large numbers in the peripheral bloodstream and block out the other normal constituents of the blood. Lymphomas are cancers of immature blood cells that grow in the bone marrow, arise in the lymph nodes and other organs of the lymphatic system. And sarcomas, as we see at the bottom, are cancers that arise from cells that are found in supporting tissues of the body, such as bone, cartilage, fat, and muscle. Another category that's not reflected up here, but you might be familiar with, is the cancer called myeloma, sometimes referred to as multiple myeloma. And myeloma is a cancer that starts in plasma cells that are found in the bone marrow. So when we talk about, for those of you that are new to the field of cancer, when we talk about names of cancers and cancer diagnoses, we usually combine these Latin prefixes that refer to a part of the body along with that larger categorical naming that we just looked at. So for example, in this picture, adeno means gland. So cancer of a gland or gland cells are called adenocarcinoma. For example, a breast adenocarcinoma, a colon adenocarcinoma. Likewise, as we see at the bottom, osteo refers to bone. So an osteosarcoma would be a cancer of the bone. Just to help you, not in the medical field, decipher some of that medical language that you run into. Okay. Move on to the next section of this presentation, which is looking at cancer screening and early detection. Some types of cancer can be found before they start to cause symptoms. So as we looked at that timeline, we said that sometimes years can elapse before a cancer is detectable, before it's large enough to cause a symptom, create a problem, draw somebody's attention to it, take you to the doctor. And so that long lead time provides us with a great opportunity to be able to find cancer as it's developing and as it's dividing, so it's detectable, but it hasn't demonstrated itself in terms of symptoms that would call your attention to them. So, and the reason that we want to find it early is because the smaller cancer is, the earlier it's found, the more treatable it is, and the greater the likelihood of the person being able to survive the cancer diagnosis. So when we talk about cancer screening, screening is checking for cancer in a person that doesn't have any symptoms of disease, like we said. So keep in mind the people that we're looking at here are an asymptomatic population of healthy individuals. And the goal of screening, as we said, is to detect cancer before it grows and spreads or metastasizes. So screening tests are not in and of themselves meant to diagnose cancer. They're meant to be able to demonstrate if there's an abnormality or not, and if there is an abnormality, further testing would be required, and those would be referred to as diagnostic tests. So the purpose of those tests would be to say, is this sort of abnormality cancer or is it not cancer? So people that have certain high-risk diseases, for example, people that have a familial hereditary genetic change that would predispose them to developing colon cancer at a very early age, for example. That population of people would be recommended to start colon cancer screening at a much earlier age. Likewise, women with a very strong family history of breast cancer would potentially start screening studies earlier than what a general risk population would. So if we look at the types of screening tests, we know that essentially, there are several diseases that are amenable to screening, and the purpose of screening, as we said, is to decrease the mortality and the number of deaths related to cancer. So we know that the use of screening mammograms is effective in reducing deaths due to breast cancer as well. We have known for a number of years that Pap tests can reduce the deaths due to cervical cancer, and certainly colon cancer, by using a variety of different tests, can reduce deaths related to colon cancer. Prostate cancer and PSA, we've got question marks because, as you know, that was standard practice for quite a long time, and now you've seen more information in the news recently, like questioning the utility of that. So there's a lot of issues. If you follow the news, either the scientific literature or the lay literature as well, you see a lot of issues related to cancer screening. And so the bottom line with cancer screening is the test needs to decrease the chance of dying from cancer. So that's asking a different thing than can it detect more cancers. The purpose is decrease the number of deaths. It's important to think about particular risks that can be associated with the screening. For example, with a colonoscopy, there's always a risk of perforation, although it doesn't happen frequently. You may have heard the terms false positive and false negative in conversations or in your reading about cancer screening. A false positive reading on a screening test means that your mammogram detected something that it called positive when indeed it wasn't cancer. And so immediately what comes to mind are the impacts of false positive results. Knowing that additional tests will be required, there's the cost of additional tests, there's potential complications with additional tests, to say nothing about the anxiety that potentially having a cancer diagnosis evokes in anyone. A false negative result, on the other hand, is also not good, but a false negative refers to the test reads negative when indeed a cancer was present. So just as devastating on that end of the coin. So the science around cancer screening continues to change, and the important thing in cancer screening is that we continue to do clinical trials that test new screening modalities, we continue to look at the evidence, we continue to look at the science, we continue to have scientific debate, and we continue to incorporate strong evidence-based practices into our recommendations and into practice. And we all know that communicating changes around screening to the public is challenging. So we watch as that unfolds in the lay literature very frequently. Okay, so let's talk for a moment about barriers to screening. So there's a whole host of them. And commonly, we know that people may be fearful of screening for a variety of reasons, one being not wanting to have that colonoscopy because, God forbid, maybe there's something there. That would be my husband. Lack of knowledge may be a reason. Finances or lack of access to screening may be a reason, as well as communication or beliefs about illnesses and other cultural things. And even like for those of you that are of the age when you need to be, participating in screening practices, we all know that it's difficult to get that mammogram scheduled, for example, because, something else just got in the way. So it's something where we all need to be knowledgeable about the screening guidelines, and we all need to be personally responsible and accountable for our own screening practices, as well as helping to educate those around us about appropriate screening practices and enabling people to do that. So cancer detection. So changes may arise in the body that give us a sign that cancer may be present. So let's talk a little bit about what those kinds of things are. So a symptom is a sign to you that something's not quite right, there's a change. And the thing to remember is that most symptoms that people experience in their bodies are not due to cancer, and to remember that early cancer usually doesn't cause pain. So let's look at some of the possible symptoms of cancer. This list might be familiar to many of you, but it's always worth repeating one more time. A thickening or a lump that wasn't there before, a new mole or a change in an existing mole, a sore that doesn't heal, hoarseness or cough that persists over time, a new change in bowel or bladder habits, having discomfort after eating, having difficulty swallowing, unexplained weight change, unusual bleeding or discharge, feeling very weak or very tired. As well, you should pay attention to your body if for any sort of unexplained symptom, commonly such as a progressive weight loss over time that you can't explain, fever, or persistent fatigue. So, and pain. So all of these are things that, people need to take personal responsibility, be vigilant about knowing your body and understanding and recognizing changes when they occur, and seeking appropriate medical advice and intervention as needed. Okay, so let's move on now to cancer diagnosis and staging. Diagnosis of cancer. So let's say you've either been through a screening test and there's an abnormal finding, or maybe the scenario is you've found a change on physical exam and there's a concern that it might be a sign of cancer. So maybe some studies have been done, but this isn't, it's accumulating, it's beginning to gather diagnostic information. It's not definitive. A biopsy or the surgical removal of a small piece of tissue for examination is the definitive diagnostic tool for establishing a diagnosis of cancer. So let's talk a little bit about that biopsy. So there's a number of ways that we can obtain the tissue, and one of the ways that we can get tissue is through a procedure called an endoscopy. And certainly for those of you in clinical practice, this is very familiar information, but maybe newer to others of you. So an endoscope is basically a long hollow tube that usually has a light on the, not usually, it has a light on the end of it, and it has little pinchers on the end of it. And that long hollow tube can be inserted into any number of openings to take a look. So when the tube is inserted into the colon, obviously that's a colonoscopy, or you can insert the tube down into the lungs, that's a bronchoscopy. You can even use that tube and make a small incision and insert the tube into a closed cavity, such as the abdomen, thereby performing what's known as a laparoscopy. You can insert it into the chest, doing a thoracoscopy, or a mediastinoscopy. And so all of these uses, these are different examples of ways that an endoscopic procedure can be used to follow up an abnormal finding for the purpose of taking a piece of tissue in an effort to establish a definitive diagnosis. Okay. Another method that's commonly used is what's called a needle biopsy. There's two different kinds of needle biopsies, the first being fine needle aspirate, commonly referred to as an FNA, as well as a core biopsy. So a needle biopsy can be used if a mass is discrete. You can sort of get it between your fingers. You can feel it underneath the skin. A common example of this, and where an FNA is commonly used, is to evaluate a breast mass. And so if you feel a breast mass, you can put a long, thin needle into it. You can withdraw cells. You can use that to figure out if that might be a cyst, which is just a benign fluid-filled sac, or if it's solid. And when those cells are withdrawn, then those cells are looked at under a microscope, and that's referred to as cytology. And so looking at those cells for cancer. So one of the benefits of doing a fine needle aspirate procedure is it's easy to do. It can be done in the office. One of the drawbacks is that you may not be able to get enough cells to definitively make a diagnosis. But FNA is used frequently. Another type of needle biopsy that can be done is referred to as a core biopsy. And as you might have guessed, a core biopsy uses a larger bore needle, and it's able to draw out a larger piece of tissue for microscopic examination. A core biopsy might be done either freehand, if you can feel that lesion, well enough and get a hold of it well enough to get the core needle into it, or in some cases, the placement of the needle may be guided by a radiology technique, for example, using ultrasound or using some sort of a 3D imaging. And the core needle has a special cutting edge on it, and as I said, it can take a larger sample of tissue, and both of these procedures are done with just a little bit of local anesthesia. And then finally, are surgical biopsies, a larger procedure done with anesthesia in an operating room, may be incisional or may be excisional, and the purpose of an excisional biopsy would be to go in and remove the entire tumor. So using breast again as an example, an excisional biopsy of a palpable mass or non-palpable mass, you remove the entire tumor or the entire mass, trying to take a rim of normal tissue along with it. Also using the breast again as an example of an incisional biopsy would be in the case of a locally advanced breast cancer, where sometimes the entire breast or much of the breast is encased in tumor, and in that situation, it's not an operable situation, but you can go in, do an incisional biopsy, and be able to take tissue for the purpose of making a diagnosis. Okay. So the next concept that we're going to talk about is what's referred to as grading. And grading is a microscopic examination of the tissue that helps determine the aggressiveness of the behavior of the cancer. So grading is done looking at tissue under the microscope, and it's looking at individual cells. And so the tumor may be defined as well-differentiated or poorly differentiated. And in a well-differentiated tumor, the cells under the microscope look and function more like the cells of the originating tissue. So using breast cancer again, the cancer cells look still somewhat like a breast cell. And so the grading scale ranges from grade 1 to grade 4. And so a well-differentiated tumor may be graded a 1 or a grade 2, and it moves down the continuum to a poorly differentiated tumor. And at that end of the spectrum, the individual cells have a bizarre and a highly abnormal appearance. There's very little structure or character of those cells that would remind you of the cell of origin. And that's a typo there. It should be grade 3 to 4 for poorly differentiated. And so what you would expect, this piece of information gives you another tidbit as you're planning for treatment and thinking about prognosis, because a well-differentiated tumor by natural history would tend to behave not as aggressively as a poorly differentiated tumor. So we'll talk now about staging of cancer. Staging, so grading was looking at an individual cell. Now we can think about staging as being about the whole body. So staging is the process that tells the clinician how far the cancer has spread throughout the body. And if we look at this as an example, so with staging, the earlier something is caught, as we've already said before a couple of times, the earlier something is caught, the better the prognosis. If it's small and can be removed, your chance of survival is much better than if it's spread either regionally or distantly in the body. So this gives you a pretty graphic demonstration of the role that stage plays in overall survival. This particular slide is using melanoma, and it shows us the 5-year survival rate for patients with melanoma by stage. So you can see on the left-hand side, stage 1, and that 1 is a little difficult to read there. The people diagnosed with stage 1 melanoma is early stage, and what that tells us is that the melanoma was not thick, it was not spread, it was very localized and very thin, and you can see here very treatable, because indeed, nearly close to 100%, somewhere over 90% of patients are alive at 5 years after a diagnosis of stage 1 melanoma. But stage 2, meaning that that tumor was either, in the case of melanoma, it was either thicker, more abnormal, a little more spread locally, that stage 2 person has about a 30% lower survival at 5 years than if it were detected earlier. And obviously with stage 3, meaning that the disease has spread, probably in the melanoma staging system, it's spread to a nearby lymph node, these people have a much worse prognosis. So this is a pretty dramatic demonstration of why detecting and finding cancer earlier leads to a better outcome. Okay, so staging is important because, as we've said, it helps to determine the extent of disease. It's critical to planning treatment. Treatment is determined by stage, and it influences the person's prognosis. And so when we look at staging, staging is focused on the most common sites for metastasis. So what does that actually mean? So when we look at any type of cancer, we know through looking at cancer over time that there's a natural progression for each different type of cancer. So we know, for example, that estrogen receptor positive breast cancer, a certain type of breast cancer, has a propensity when it metastasizes to move first to the bones. We also know that estrogen receptor negative breast cancer may move to other places, for example, the lungs and the brain and the liver. So with each disease, we basically know where we can expect cancer to spread, use that information to define what the staging workup for somebody diagnosed with a new cancer would be. And so the kinds of things that are included in a staging evaluation would include a physical exam, would be looking at laboratory tests, and the types of lab tests that would be considered would be a complete blood cell count, doing a regular chemistry panel. There are a number of disease-specific tumor markers, and some are listed here, that help us to provide prognostic information about that disease. And some of these tumor markers are really helpful tools in following response to treatment or potentially recurrence of disease into the future. But so for particular types of cancer, a disease-specific tumor marker may be evaluated. Staging workups usually include a variety of radiologic studies, and these, again, are going to be dictated by where that particular type of cancer is prone to spread. And so any one of these, any combination of these might be appropriately used for a particular cancer diagnosis. There's 4 common stages of cancer. The first being in situ disease. This is early cancer that's not spread to neighboring tissues. An example of this, you may be familiar with the term DCIS, which stands for ductal carcinoma in situ. The next would be local disease, which means that cancer is only found in the organ in which it started to grow. So, if you will, it's localized to right in the area of origin. Regional disease means that cancer has spread to surrounding tissues or to lymph nodes. So you recall in the earlier diagram where the cells were being shed into the lymphatic system and into the bloodstream. So we see the result of that with cancer being involved in the lymph nodes. And then distant spread means the cancer obviously has spread to other organs or other systems of the body. So when we look at staging, there's a number of classification systems that are used. And the typical classification system that's used for solid tumors is what is referred to as the TNM system, and it stands for tumor size, lymph node status, and distant metastasis. So when this staging criteria is applied, there's a little subscript numbers that are associated with it. So, for example, in a breast tumor, if the tumor is between, say, 1 and 2 centimeters, that would be denoted as a T1 tumor size. A slightly larger tumor might be denoted as a T2 tumor size. The same applies with lymph node status. If there's no lymph nodes involved, then it would be denoted as N0. If there are positive lymph nodes, it would be denoted as an N1. And the same for metastatic disease. No distant disease would be an M0, and the presence of metastatic disease would be an M1. And so when we look at individual cancer diagnoses, it's very common. You'll commonly see this TNM staging written down, and you might see a T1, N1, M0 type of thing. Hematologic malignancies, on the other hand, have very specialized staging systems. These are applied to leukemias, lymphomas, and myeloma. And staging, it's important to know about staging that lots of evidence is collected looking at disease over time, and the purpose of these staging systems are to be able to provide prognostic information and integrate that with informing decisions about treatment. So to summarize, we're really at the end of our content, and so let's just take a quick look back at what we've talked about today and leave you with some take-home thoughts. So basically, number 1, cancer results when genetic changes and mutations overcome the normal control mechanisms. Cancer is characterized by its ability to invade locally and metastasize widely. Prevention is key. Screening asymptomatic populations can decrease deaths from colon cancer, breast cancer, and cervical cancer. And we use biopsies to obtain tissue. Tissue provides the definitive diagnosis. When we talk about grade, we're referring to the appearance of individual cancer cells. When we talk about stage, we're talking about the whole body and the extent of cancer across the body. And to know that resources are available. And speaking of resources, just referring you again back to the cancer.gov website, and here you're going to find information that's relative to both health professionals and patients and lay audiences. And you'll find a wealth of information online, and it's divided up according to diseases as well as according to various cancer topics. You'll find information in each of the cancer diagnoses that's tailored for health professionals as well as for lay audiences. The other thing that, if you're not already aware of the National Cancer Institute's Cancer Information Service, the 1-800-4-CANCER phone number, as it's been known for over 30 years of service now. So the CIS is manned with, or personed with, information specialists who are very, very well trained and use NCI's cancer information resources to answer questions and to be able to discuss cancer topics with public audiences. And so for those of you in the health professions that work with patients, I think that the Cancer Information Service can really be seen as an adjunct to the teaching that you do with patients, because you've got a lot of information to impart to people, particularly around a new diagnosis. And I think I would encourage you to leave patients with the 1-800-4-CANCER phone number, and they can use the information specialist to help them continue that discussion, to be able to answer questions, and to really empower the patient with resources that are available. So we've come to the end of my content, and I hope you all found this helpful, and now we'll turn it over for questions and answers.
Great. Thank you, Linda, for laying the foundation for our understanding of cancer with your presentation today. The second half of this call will be devoted to your questions, and we encourage all of you to be active participants. In addition to having Linda available to answer any questions you might have, we also have with us today Ms. Annette Galassi with NCI's Office of Communications and Education. Annette is a registered nurse with over 25 years of experience in oncology. Annette will be moderating the Q&A session and answering any questions that you might have today. As a reminder, please press *1 to be placed in the queue to ask your questions. Or if you would prefer, you can also submit your questions using the Q&A feature at the top of the screen.
Thanks, Candace. We do have one question, and that is whether the slides will be available to the attendees after today's presentation. And so we can make arrangements for the posting of those slides along with the posting of the audio file on the education and training page of the cancer.gov website. Okay. Operator, do we have any questions on the line yet?
I do have one question here. One moment. Karen Gregory, your line is open.
Yes, my question was just answered about the slides being placed online. I was unable, for some reason the link would not open. I tried various ways to have that open, but I was able to listen to the entire call. So thank you very much.
Sure. We're sorry that that happened to you today, but we'll be posting those slides.
Thank you.
And right now, I show no further questions. As a reminder, if you'd like to ask a question over the phone, please press *1. Please unmute your phone and record your name. One moment to see if we have any other questions over the phone.
Okay, we do have one question that's come in online, and that is in reference to recommended ages for various types of screening and how often one should get screened. So let's take those sort of one at a time. The first perhaps being what has become the most controversial, and that is screening for breast cancer. And you all may have been privy to the kerfuffle, if you will, that was in the media about a year or so ago when the U.S. Preventive Services Task Force came out and changed their recommendations for screening mammograms somewhat. Our rule of thumb is to start screening mammography at the age of 50, that consideration should be given to one's family history and personal history, and also this should be done in the context of a discussion with one's health care provider so that patients can really be making an informed decision about what the risks and the benefits are of screening mammography. And that, in fact, really goes not only for screening mammography, but for other diseases as well. Okay, let's next take cervical cancer. That's the other big cancer that we screen for. And cervical cancer screening is done with Pap testing, and that usually begins at the age at which a young woman becomes sexually active. And that is, of course, going to vary from woman to woman. And again, that's a discussion that is held with the woman and her healthcare provider as to when exactly to begin those screenings. I guess next group of diseases, or the next disease that we screen for, is colon cancer. And let me just remind you all that there are really several modalities that can be used for colon cancer screening. We have fecal occult blood testing. We have immunohistochemical testing. We have flexible sphygmoidoscopy, double contrast barium enema, and screening colonoscopy. Those really are the range of screening studies that can be done for colon cancer. Screening should begin at the age of 50, again, unless there is some sort of a family history that necessitates screening to begin earlier. If there is a family history of early onset colon cancer, then the rule of thumb for that tends to be 5 years sooner than the youngest person that was diagnosed. So if there's a strong family history of colon cancer and the first or the youngest person to get colon cancer in that family was 45 years old, then the recommendation would be first-degree relatives begin screening at 40. So those are just some general rules of thumb for breast, cervical, and colon cancer screening. And as Linda pointed out earlier, those are the diseases for which we know screening does make a difference in terms of mortality. Okay, we have another question. The question is around PSA, and well, I think we covered this. It was around PSA, mammography, and Pap testing. I guess the only thing that we really didn't cover is PSA. And I know Linda alluded to the controversy surrounding PSA screening, and I think that the controversy of that really is related to the fact that, you know, do we know that screening with PSA saves lives? And in order to answer that question, NCI has undertaken the DLCO trial, the prostate, lung, ovarian, and colon cancer screening trial. Very large screening trial that involved, I want to say off the top of my head, over 10,000 participants. Linda might know a little bit better than me what that number was. And we are awaiting that data to find out what effects screening with PSA for prostate cancer will have. So, you know, right now, the recommendations for prostate cancer screening do tend to be variable. You have organizations like professional societies of urologists that do tend to recommend PSA screening, but according to the U.S. Preventive Services Task Force recommendations, which is what guides our practice here, it is unclear what the benefit of screening with PSA is. All right.
I do have a question over the phone. Would you like to take that?
Sure.
Okay. Azul Saroni, your line is open.
Hi. My question is, will advances in personalized medicine for cancer impact screening and early detection, given that doctors can now weigh in one's genetic background and medical history?
I think that that's a fabulous question, Zul, and it's nice to hear your voice, by the way. I think that as we learn more and more about the biology of cancer, we'll have a better understanding of people's risk for cancer. I don't think we're there quite yet. We are using tumor profiling in some diseases to make treatment decisions. For example, the aggressiveness of adjuvant therapy for breast cancer is being dictated by some things that we know about, excuse me, people's tumors, like their HER2 status. I don't think that we're quite there yet when it comes to screening. There are genetic alterations that we know exist in certain families that increase their risk for the development of cancer, and factor that in when making screening recommendations, and in some cases recommendations for prophylactic surgery to people with genetic alterations. But although we're finding various alterations as we study tumors, we're not necessarily at the point where we know what to do with that information. Linda, I don't know if there's anything you want to add to that.
Well, I would just add, you might have read, or others of you might have read, about the need to establish validated biomarkers. So biomarkers being an indicator maybe of susceptibility, maybe of risk, but being able to impart additional and important information sort of in that early phase, so we can identify people using a blood test about who's at high risk and start to characterize people's risk categories and work towards prevention. And one of the difficulties in that area is that when you establish a test, you've got to get to the point where that test is standardized, that everybody that does the test is using the same technology, and the technology is yielding a consistent and standardized result. And so there's a lot of effort underway now to validate biomarkers, because a lot of biomarkers have surfaced as effective biomarkers of predictability or susceptibility, but there needs to be a process of standardization where when one lab does it, equivalent and consistent results are received across the board. So I think that's another area to keep an eye on, and it's an area that holds a lot of promise. Thanks for the question, Bill. That was great.
And right now, I show no further questions over the phone. As a reminder, if you'd like to ask a question over the phone, please press *1. Please unmute your phone and record your name. One moment to see if we have any other questions over the phone.
Operator, while we're waiting, we do have a question about where one can find cancer education information for non-English speaking populations with high levels of illiteracy. So this feels like a good opportunity to make a plug for cancer.gov Espanol. We do have a dedicated website for Spanish-speaking individuals and health professionals as well. We also have a lot of our materials that are available in Spanish, and with a focus on plain language, so that they are more approachable, if you will, for people with low literacy levels. Finally, we have very few materials available in some Vietnamese, I believe it is, dialects, but those are primarily for cervical cancer screening. I don't think that there is any information there for breast cancer screening, and I don't think we have any treatment-related information. We do have a web page on our website. You can find a link to it if you go to the cancer.gov website. On the left-hand bar, you will see a link to our publications ordering service. And if you click on that link, you can search for publications by language, by literacy, by cancer topics. So I would encourage you to go there and take a look at what we have available. Okay.
I do have another question over the phone. Would you like to take that?
Sure.
Aubrey, your line is open.
Hi. Yes, I wanted to follow up on that question for non-English speaking populations and those with low literacy. What materials are you aware of that have been designed for children, whether it's either pediatric cancer patients or children of that have relatives who are going through cancer, or just the general population starting to educate kids about what cancer is and how to prevent it through healthy lifestyle choices? Are you aware of any documentation on this for children?
Great question. We do. Let me start with the easier piece of that, and that is to mention that we do have a page on cancer.gov that is directed specifically toward adolescents and young adults with cancer. And I believe you can, the easiest way to find it is by going to the search box on cancer.gov in the upper right-hand corner and just typing in young adult and cancer. So we have something for that population. We also have materials for children whose parents have been diagnosed with cancer. And I do not think that we have any materials that are specifically for children diagnosed with cancer. You might want to check APON's website. That's the Association of Pediatric Hematology Oncology Nurses. And they may well have some patient information materials on that website, or would be a good place to at least ask the question if they could give you better direction. So I would, as I said, look at cancer.gov at the adolescent, young adult, look at what we have for children when parents have been diagnosed with cancer, and then try the APON website for materials specifically directed toward children. Final thought that I have is that the Center for Disease Control might have some information. I am not sure. Linda mentioned the Understanding Cancer series. That actually is part of a larger life science curriculum but that again is aimed at high school science teachers. It's fairly sophisticated in terms of the content. But if you're in public health nursing and going into a high school classroom, that might be a good resource for you to use as well.
Thank you.
I do have another question over the phone.
Sure.
Akiba, your line is open.
Hello. I was just curious to know if you had any cultural-specific documentation of how different cultures handle cancer.
We don't have printed materials per se. We have done webinars through the NCCC program, that is the National Cancer Institute community clinical oncology program. They have done a series of webinars for their staff on cultural considerations. We are looking for additional topics for our Cancer Classroom series, and if the audience members think that that might be a useful series for us to undertake, doing a group of webinars on the various cultural groups that we work with here in the United States, and what the cultural considerations are with those groups and cancer, that would be something that we would be interested in getting some feedback on. There will be an opportunity at the end of the call. Candace will give you some information about completing a public comment option, and feel free to type in your thoughts and desires when it comes to additional trainings for this series.
Thank you.
And right now, I show no further questions over the phone.
Okay. Candace is giving me the signal that we're just about out of time, so let me stop and let me thank you all for the opportunity to answer at least some of your questions today, and thank Linda for really doing a fabulous job kicking off our series.
Great. And thank you again, Annette and Linda, for handling our questions for today. And I want to thank each of you for participation in our seminar today, our first session in our Cancer Classroom pilot. Your feedback is very important to us as we continue moving along plans for this Cancer Classroom series, and we invite your public comments. These results will let us determine whether or not we move forward offering additional sessions of Cancer Classroom, and this link will be emailed to you following our call today. We hope you will join us again on May 17th for our second session in our 4-session pilot from 2 to 3:30 Eastern as we continue to explore the topic of understanding cancer. May's session will build upon the topics and concepts that were introduced